Thanks for your attention, and sorry to subject you to all of this in one quick hour. So we're going to talk now about lessons specifically from malpractice claims. Given my specialty, some of these are a little more focused on oculofacial plastic surgery. Just a little background about OMIC. Some of you are probably OMIC insured. 35-year history, 4,500 total claims. 21% of those ended up in indemnity payments of about $160 million. There have been close to 190 trials, mostly defense verdicts, 89%. We're the largest insurer of ophthalmologists in the world. A lot of useful experience that we can glean from looking back at our experience over the last several decades. Looking particularly at oculoplastic claims, I did a study a few years ago that was published in the Blue Journal, looking at sort of why people sue their ophthalmologist, and cosmetically unhappy was actually the single most common thing. Expected complication, number 2, a delay or failure to diagnose, number 3, and then innocent bystanders, just like the anesthesia person gets sued and you get sued too. Standard of care not met. You can see the rate of indemnity payment was much higher. I'm not sure where that one might be. Way more patient if you haven't met the standard of care. If you don't have a good informed consent, 100% of the time you're going to lose that one. If you alter the records, 100% of the time you're going to lose that one. Thankfully, with EMR now, it's a little harder to change the records retrospectively. But if you're still on paper, remember that changing the records will always lead to a failure, or you or the insurance company will end up paying, and you'll lose that case. In terms of the amount of indemnity payment, how much we have to settle for, or they end up having a jury rule for, the ones that are by far and away the most expensive are delay or failure to diagnose. So I'm going to concentrate on those over the course of the next half hour. So this can happen anywhere, even on your cell phone, as I'm going to come to. So I've got a few things to talk about: giant cell arteritis, malignancies, retrobulbar hemorrhage again. I think I'm going to skip the cerebrospinal fluid leak one, globe perforation, acanthamoeba. So here's giant cell arteritis. I tried to match, the residents had such witty talk names. I tried to throw in something, so those of you who are Who fans might recognize this. Anyway, we've had 18 cases related to GCA, and in 12 of them, it wasn't even it was not even in the differential diagnosis, and in the other 6, the ophthalmologist really didn't do anything about it, even though he or she did consider GCA. Why is it so hard to diagnose? Well, the symptoms are variable in time and among people. Patients don't really know what's important, so they don't know what to tell you. We often don't take the greatest histories, as I said, and because we're eye doctors and we don't think we need to pay much attention. I will admit to being guilty of telling my staff, like, if they tell you they have diarrhea, don't write it down. I don't want to know. I don't need to do anything about it. It's not my problem. But sometimes it is our problem, and GCA is one of those cases. So here's one: 82-year-old man with blurred vision, headaches, episodes that are coming and going, resolving spontaneously. He had a blackout. Exam seems normal. Doctor from South Africa who gave a great talk. Can I ask you a question? This story, what questions would you want to ask this patient? Sorry, I didn't remember your name, although you were great, and I like the Springboks, and I have a jersey.
Her name is Emma, and I'm bringing the microphone.
And Emma, if you want to take the 5th, you may not have it in South Africa, but we have it here.
I had to ask what the 5th was. I would like to ask the patient, do they have any jaw claudication symptoms?
Sure. That'd be a good question. Anything else? How about unexplained weight loss?
Right, yeah.
Go with that one too.
Yeah, maybe some malaise as well.
Yeah, those are all reasonable questions.
Things
we don't normally ask, right?
Yeah.
So this particular, no, he wasn't asked those questions. 9 days later, ends up in the emergency room, hand motion vision for both eyes, then gets his temporal artery biopsy. Not so good. So, although they diagnosed it as migraines, they never really asked what this meant. And I want to make this point that I have in parentheses here. That a lot of us don't look at we have our techs take histories, but we may not really look at what they write down. And so we might not get that information anyway. This headache, visual changes, you should be thinking from this day forward, that could be GCA. This ended up settling for $450,000. Systemic symptoms. So sometimes they're elicited, sometimes they're not. Headache is the most common symptom. Scalp tenderness, jaw pain, fever, weight loss. The plaintiff experts will uniformly say that had the ophthalmologist taken a more thorough history, made the diagnosis earlier, you could have prevented the vision loss, and unfortunately it's true. The systemic symptoms turn out to be the key issue. If there's only vision symptoms and they end up having GCA, we will win. The ophthalmologist will prevail. If there are systemic symptoms with some kind of visual change, which is why they're usually there in our office because of the visual change, but we may or may not catch the systemic symptoms, the plaintiff will end up with the judgment on their side. So recent headaches, scalp tenderness, jaw pain, fever, weight loss, make the diagnosis. Second case, 73-year-old man, headache, curtain over the vision, string of confetti, initial diagnosis PVD. 4 days later, though, has a APD and residual temporal island. Final diagnosis, giant cell arteritis, settled for $400,000. What can we learn from that? Again, pain with visual disturbance is GCA. I think we all probably know that PVDs don't cause headaches. And so don't jump to that idea that the PVD could be part of it. You have a very short window to make the diagnosis. Within a week, someone can be blind. And the idea of what a curtain means matters. You know, we think of a curtain maybe as indicative of a retinal detachment. The patient might mean something else. And so understanding what they say and what it could imply ends up being an important thing. Make sure you document your findings in the chart and have a prioritized differential diagnosis where you rule out the worst things first, like giant cell arteritis. Another case, 78-year-old woman, 2-week history of headache, pain in the neck and temples, a new yellow spot in the corner of her eye, calls the office to find out if she can stop her alpha-GAN because she's getting headaches. Later calls back and says she sees some spots. Next day calls and says she has a lavender patch with sparkles. You can just imagine your receptionist getting these phone calls about sparkles and lavender spots and yellow spots. They don't know what to do with this, right? A couple days later, has some macular edema and a vein occlusion, told to come back in a month. Comes back 5 days later, with 2,400 in one eye, count fingers in the other. Obviously, at this point, we got a problem. Although this case didn't settle for much money, again, the diagnosis is giant cell arteritis, could have been prevented by a little more careful history at the time of the initial visit there when the vision was still 20/30 and 20/40, because all the headaches with these visual changes should make you think, what? Yes, right. I've hammered this home, maybe? All right. So pay attention to the systemic symptoms when the vision's good, and beware when there's any strange visual disturbances, especially if the findings don't match the history. Don't jump to something like retinal migraine. Useful information, have a low threshold to order, SED rate, CRP, CBCs. Low threshold to get a temporal artery biopsy, it's pretty easy. And most non-diabetic patients can tolerate a couple of days of prednisone while you sort this out. And no one will end up faulting you for doing that, to be more careful. Learn to take a great history. Most of us are not that great at this. And it turns out that lots of studies have been done that taking a good history, being good as a diagnostician will save you in a lot of different ways. This article by Myopolis was very much worth reading if you're interested in that subject. And you can find out a lot more information on GCA from our OMIC website. All right, next case. Any questions on giant cell arteritis? I pretty much hammered that, I think. All right. So a 57-year-old retired woman referred to her optometrist to one of our insured doctors for a mass at her left lower lid. It was called a pyogenic granuloma and removed without a biopsy. See what those look like. These are pictures, we don't have a picture of the actual patient, but these are pictures of things that could be called a pyogenic granuloma that you might see in your office. 3 years later, she came back to the same doctor for the same problem. This time it was called a chalazion with a pyogenic granuloma. Again, it was removed without biopsy. Unfortunately, the insured doctor's consent says that biopsies are necessary to distinguish between benign tumors and cancerous ones. It's just part of their routine language that's in there, but they didn't send it. A month later, same problem, unresolved, recommended Maxitrol. 3 months later, occasionally had some bleeding, offered the same treatment, nothing was done. She ended up finding help elsewhere. So she ended up seeing her optometrist for the bleeding, who said, yeah, I'm going to send you to another specialist. Got a second opinion. Ended up being sebaceous carcinoma, as we all remember from residency, as one of the great masqueraders. Ended up having Mohs surgery. So just a little bit about sebaceous carcinoma, third most common eyelid cancer, 6% fatality rate overall. The eyelid is the most common site on the body, about a third of all of the sebaceous carcinomas are there. Commonly masquerades as a chalazion. Wide local excision, map biopsies, cryotherapy, external beam radiation, a little bit more complicated than basal or squamous cell. Examples of some patients from my practice that have had this. Can be terrible like that, or not so terrible like that. A few more. Pretty terrible. So ended up having Mohs surgery, oculoplastic reconstruction. Later on had metastatic carcinoma to the neck, had to have a neck dissection. Of course, after all of this treatment and being cancer-free a few years later, alleged malpractice against the original oculoplastic surgeon who removed it twice but didn't send it for biopsy. So the standard of care probably is biopsy, is what the plaintiff's attorney thought. With the slow, painless growth, failure to resolve with steroids, all of those things should have heightened the suspicion for malignancy. An atypical one, even more suspicious potentially at the second time around. Timely biopsy and Mohs surgery would have prevented metastatic spread. For the defense, the attorneys there say, well, it was kind of typical, and you don't have to biopsy every pyogenic granuloma. And the second time it was kind of typical for a chalazion, and you don't necessarily have to biopsy that either. Maybe even if they had biopsy, they already would have been metastatic, and the outcome would have been the same. I can tell you that didn't end up working out that well. And although they didn't claim punitive damages, they asked for $2 million. The jury verdict range was estimated to be somewhere close to that, with a less than 40% chance of a defense verdict based on the experts who look at these kinds of things. Ended up getting settled for about $700,000. So kind of a scary case. What can we learn from this? The standard of care is local and fluid. Whether or not to biopsy is really going to be based on would a similarly trained physician in the same community, different in Denver perhaps than it would be in Omaha, where you're having your next meeting, for example. That may come into it. But in general, it makes sense to have a high suspicion for malignancy, or at least possible malignancies with things that are recurrent. Strongly consider biopsy of anything that doesn't seem like it's normal. And don't get fooled by unconscious cognitive biases. You probably have heard a lot about these lately. There have been a lot in the news. The idea of an anchor bias, that the first thing you think it is ends up being the thing you continue to think it is even as time goes by. It's that idea of once the idea is in your head, it's hard to get a different idea in your head. We have a tendency to rely too heavily on the first piece of information we receive and the first information that we get. There's a thing called confirmation bias that also, we sort of say, as if you see, it would be the idea of you get the idea that your spouse could be cheating on you, and then you hear that they are on the phone with a person of the opposite gender, and that's confirming this idea. Clearly not necessarily right or correct or accurate. The idea that the written diagnosis that's there from the very first visit becomes the thing they're following up for. And that may happen to a lot of us. I don't know about your EMR that you use in your particular practices, but it may be that it says, follow up for chalazion or follow up for pyogenic granuloma. And then in your brain, you're not thinking, well, wait a minute, what if this isn't a pyogenic granuloma? And you need to get away from this idea of this anchor bias. So more attention to patient history, more attention to the differential diagnosis as it evolves, and be open to the possibility that your original diagnosis was wrong. Just a nice picture. All right, so any questions about that? All right. 51-year-old female part-time hospice nurse comes in seeking help for her eye. She's had a thyroidectomy for her thyroid eye disease, wears contact lenses, has high blood pressure, and is overweight, has had some large volume liposuction, and is on phentermine. She went through Google, she found an oculoplastic surgeon 3.5 hours away from her house and wanted to get a blepharoplasty. The original evaluation showed that vision was normal, pupils are normal, a little bit of punctate epitheliopathy, some proptosis with retraction, dermatochalasis, dry eyes. So let's start with some increased artificial tears and ointments. And sure, you want a cosmetic blepharoplasty, we'll do it for you. So I would ask the question, are you concerned that she has doctor shopped and didn't like the advice she got locally? I'm sorry if I didn't say that out loud. That she had to go 3.5 hours away to find a doctor who might give her what she wanted. Probably should be. And one of the options is to think like, wow, I'm so great, they'll drive hours to see me. The other one is, maybe they're trying to get something that they couldn't get locally, and maybe I shouldn't be giving it to them. So you'd have to take a great history from her and understood that your greatness might not be the only reason that she came. And the more history of this person is that it turns out, I said hospice nurse, well, those other things factor in, that she has their active Graves' disease, let's not forget that. She was told she might need an orbital decompression by a doctor locally who she said she didn't want. Her contact lens thing, well, she did have the little punctate epitheliopathy, but she also has a history of SLK, peripheral vascularization, not compliant with her contact lens wear. She's not compliant with her tenoretic. And her liposuction was complicated by blood loss and anasarca, and she didn't pay attention to the post-op regimen. So more history about this patient makes you say, wow, this is maybe not somebody I want to operate on. But if you look at it, just say, well, she doesn't look that bad. I can probably take care of this, and boy, I'm great. Anyway, uncomplicated upper blepharoplasty was done. Blood pressure was high during the operation. They controlled it with hydralazine. But she drove back and stayed up with her family, again, not listening to the instructions of what she was supposed to do. And sometime between 8 and 9 in the morning, she experienced sudden intense right eye pressure, couldn't see, and had blood pouring down her face. Called the surgeon's staff at 9:22. The surgeon spoke to her at 9:26. And she sent this picture to the surgeon on his cell phone. So essentially, you can say a diagnosis was made by the surgeon based on the phone call and this photograph that was sent to him. And he said, please drive to my office, 3.5 hours away. Come right now. And don't stop at McDonald's. Later on, the surgeon said months later in the EMR that he had attempted to call en route to see whether she was still doing well, to see whether she should be redirected somewhere else, but her cell phone hadn't been charged because she was staying up, hanging out with her family, so there was no way to contact her. So she did arrive 5 hours after the phone call, had light perception vision from the involved eye, reduced movement, probably not normal pupils in confrontation visual field, but that was what was documented in the chart. So he did a lateral canthotomy, evacuated the clot, started steroids and antibiotics, but she never ended up recovering any useful vision from that eye. Too much time had passed. Plaintiff's expert on this case said, boy, it was game over as soon as the surgeon decided to have her drive 3.5 hours, which ended up being 5. And he knew there was a bleed, and he had pictures to confirm it. So he could have talked to an ER provider or somebody local to her, or found someone who was in a city nearby her who could have taken care of her. And although I won't disclose the state where this happened, that was true. That could have happened. The defense expert tried to say instead, well, the standard of care was met. There's no guarantee you'd be able to find somebody or that an ER would know what to do. In the best circumstances, even that might not have saved her eyesight. And hard to know when the bleeding really started, and the literature is not definitive. The monkey study that some of you may be aware of from Dr. Hera on ligating optic nerves may or may not have any real value here. So the summary is, is it an uncertain diagnosis or is it a delay in treatment? Case hinges on the surgeon's instructions to the patient when she called with acute bleeding. The surgeon may have panicked, but it is reasonable to suggest that a faster option was available and might have been better. It might have been the same, but directing her to an emergency room would have been closer to the standard of care in most places. And in the end, it's a short story of a nice lady who was blind in one eye after cosmetic eyelid surgery. So this case settled for $700,000. What can we learn? Well, retrobulbar hemorrhage is a big deal. Time is of the essence. Although the literature is not definitive, certainly hours is not how much time you have. And certainly 3.5 hours, no way. In terms of whether or not there's somebody who could have helped, even making a personal phone call to the emergency room that's closer to where the patient lives, or trying to look quickly in the directory to find out who of your colleagues might be able to help, probably is the more defensible option. This is two patients of mine who have had retrobulbar hemorrhages so this can happen to, I think, anybody who's doing this type of surgery. And how many people here do blepharoplasties or some other kind of eyelid surgery like that? Yeah, the majority of us. So this is always a risk. This is a nurse that I saw on Christmas Day, 2 days after she'd had a blepharoplasty. Thank God she did well. So in terms of high blood pressure, we talked about this before, but I'll just bring it up again. Canceling surgery if the blood pressure's high, although the surgeon probably was unaware that she had been non-compliant. Anesthesia maybe could have provided a little more information about this. Certainly if you are aware, it makes sense to reschedule. Orbital congestion and proptosis make surgery more difficult, but had we got a little more information about her history, that might have led to a different treatment plan. That's not the same patient, sorry, just a proptosis patient. And then the factual errors in the notes didn't help here. The idea that the post-op vision was 20/50 when it was light perception later, and normal visual fields, and then current. This may happen in a lot of medical record systems where the last results get automatically pre-populated into the current visit unless you change it. That's generally a bad idea. And then having addenda that you add later on, like, oh, I forgot to write this down, and you add it a month later, again, doesn't really help you. A lot of reasons to just say no. Certainly the patient is at blame here, but in the end, that's not how it works. All right. I thought I was gonna skip this case, but so I'm gonna just quickly go through it because I don't think we won't have time. This is a cerebrospinal fluid leak, and I don't want to concentrate on this too much. All right, so I'm going to talk about anchor bias again. So very busy multi-doctor ophthalmology practice. Middle-aged adult male comes in, 2-day history of pain, redness, light sensitivity. Recently changed from glasses to contact lenses, was worried that he might have scratched his eyes. Vision's still pretty good. 2+ conjunctival injection, diagnosed with conjunctivitis, and given some Neopoly drops. Subsequently, patient is a very busy one, seeing up to 90 patients per doctor per day. Is that more than most of you see? I hope, because that's a pretty dangerous number. Same doctor, worsening vision, burning pain. Now that vision's 2200 in 2070, but the exam findings look about the same. Adds Empathetic. 5 days later, one of the partners ends up seeing a constant burning, photophobia, vision's 2200, 2100. No one's reevaluating here. People are just going along with this is conjunctivitis. We're going to switch over from Maxitrol to Tobradex, and we'll see what happens. Come back next week. A week later, comes back to the first doctor. Vision's a little bit better now at 20/50. Says it looks a little bit better. Keep on with the drops. 6 days later, the patient ends up seeing the PCP, who becomes very worried and arranges an urgent second opinion elsewhere. So this is what the patient ends up looking like. 21 days after the initial visit, the other doctor elicited that there was fishing in a lake a few days before onset. No one else had asked. At this point, vision's 2800, making you wonder if it really was 2050 a few days earlier, with this diffuse corneal haze and ring infiltrate. I think we had a case of this earlier, or could have been the case of this earlier with the proparacaine or tetracaine, which, by the way, the patient might have stolen too. That happens. Anyway, acanthamoeba, confirmed for this case, bilateral. Yeah, not good. So plaintiffs argued that the doctors failed to appreciate that the condition was worsening, and throughout the care stuck with this anchor bias, kind of continued with this diagnosis of conjunctivitis, and never really thought something else could be going on. They were too busy, had too many patients coming in at 90 patients a day per doctor, and just couldn't manage this. Defense said, well, early diagnosis of acanthamoeba is within 15 to 30 days, so 21 days isn't that far. And the outcome's pretty bad no matter what happens with this. And eventually they would have made the right diagnosis. I said that one, sorry. So months of drug treatment, cornea transplants, glaucoma surgery, final vision, count fingers, and light perception. Could it have played out differently if our insured group had made the right diagnosis at about the same time? Don't know. The upper estimate of damages was $3.9 million from the plaintiff. This ended up getting settled for $2.6 million. So bilateral, functional blindness in a young man. What can we learn from this? Again, taking a great history is important. Getting the story, the idea that they had been fishing in a lake with their new contact lenses maybe would have been valuable to know from the beginning. It turns out that women are better at this than men, so take a bow, all of the women in the room. Men, we can learn to talk with our patients a little bit more and be less likely to jump to conclusions. Be careful to ask the appropriate questions that might matter. And then again, come back to this idea of being open to changing your diagnosis anytime it seems like it's necessary. This idea of anchor bias is a good one to remember. The anchor here was the initial diagnosis of conjunctivitis. Anything that later on seemed to confirm that is this confirmation bias, and you need to have conscious effort to overcome these things to not follow in that same path and make the right choice. So you can insure against indemnity payments, which is what you do with your malpractice insurance, but you can't insure against all the lost time, the stress, the added work, the damage to your reputation from having one of these cases go bad against you. So if you need help, every insurance company has early assistance and intervention lines that will help you. You can get help from colleagues who will talk you through the process. Be careful whenever you have a patient who you think might be getting in trouble, that you treat them as like a VIP person. I like the Godfather picture over there. Keep your friends close, but your enemies closer. Not that that patient is going to become your enemy, but you want to make sure they don't. And so make sure they have an easy way. Showing that you're sorry, but not taking blame for it, by the way, can sometimes work. Provide great customer service. Being defensive or silent doesn't help at all. Magically thinking it's going to somehow go away isn't going to help. We have a high ethical bar to be honest with our patients and tell them what we think is wrong and not keep it from them once we have some idea. And then there's I'm sorry laws that in a bunch of the states, and you can see whether your state's on the list, have laws that make it not admissible as evidence of guilt if you say that you are sorry they're having this difficult time or sorry that they're having this bad outcome. Obviously, it's a little bit different if you say, I did something wrong and that's my fault. Most of us probably wouldn't say that, but if you say, I'm sorry that you're having this difficult time and I'm going to do everything I can to help you, that helps to diffuse anger, it helps to make you look less arrogant, like you really care, and it helps to prevent a lawsuit. So in all of those states, you can do this legally without finding yourself them saying later on, well, he said he's sorry, or she said she's sorry. Remember that diagnostic mistakes can be disastrous and costly. We have a lot of strategies to try to avoid those. And if you do have an error, open communication with the patient and conversation with risk management at your malpractice carrier will probably help you. Thank you very much. Happy to take any questions. Sorry if I went over.
You're good.
Any questions?
Yes. Can you speak at all to the risk associated with the delay in getting to the physician? Meaning everybody probably has people answering the phone. I've gone and sat in the little area where they answer the phone saying, tell me what patients are saying to you. These are key things. Have they had surgery? Have they had an injection? I need to see these patients right away. But can you speak at all to the risk to the MD associated with delay in getting to them?
So there's yeah, I can. There's two circumstances there to consider. The one is a patient that you've never seen, who is trying to get in to see you for the first time. And in general, if you've got good, reasonable triage policies, you're not responsible for someone that you don't have a doctor-patient relationship with. So that if it's difficult for them to get in, if they have to wait a week but they don't have any relationship with you whatsoever, then you're not liable for them not being able to get in for a week, unless you took a phone call or got some other kind of communication that you accepted, so to speak, from a referring doctor telling you about the situation, and then you don't get them in. So if you're, let's say you're a retina specialist and you get a call from your local cataract colleague that you have a dropped nucleus and we need to get that person in, and you don't do anything about it, and time goes by and they end up with a complication from that, then you are liable, because then you essentially accepted care of the patient even though you didn't have a relationship yet with them directly. So those two circumstances are slightly different. The other circumstance is the one where you have an existing patient, an established person in your practice, who calls with a problem, like the little lady with the twinkles in the vision and the purple colors, who already is a patient of the practice. And then it does matter that that the people answering the phone are able to provide adequate information. And probably one of the answers is on the OMIC website, but also easy to find on the internet, are all sorts of triage checklists that they can use. Checklists are a great idea to have them plasticated near your front desk so that they can quickly look and ask the right questions, or follow up on when they say particular things. Say, wait a minute, tell me more about that pain. Tell me what that's like. Obviously, it slows down the flow of things at the front desk, but it's a necessary step. And then having an open policy that your front desk can come to talk to either you or a knowledgeable tech in your practice to help answer questions. If they're worried that this person maybe does need to be seen, or they're not sure if they do, that they can come either ask you or one of your techs who might know more and make that decision. So if you have policies that work that way, it's much easier to defend if something does fall through the cracks than if you don't have any policies and procedures like that. If the front desk could testify, if they were asked, if they were deposed, actually, she never wants me to interrupt her during the day. I'm not allowed to talk to her at all, which we've heard some people like that. Then, that's a lot harder to defend. Does that answer your question?
Here.
Yes.
Two questions, maybe one of them you just answered. If your front desk or a resident talks to a patient, but you never even hear about it, could you still be liable if there's some documentation?
Unfortunately, yes, because it depends on the circumstances. But if the front desk talks to a new patient and they're unfortunately considered as an extension of you under the law, they're employed by you and authorized by you in a way. And so if they take a phone call and make an appointment, and it turns out that the story that they got or the appointment that they made is not right, then you could end up being liable. Part of it is knowing a little bit about your staff and the type of patients that you see. The kind of person who gets referred to me commonly where they have like a droopy eyelid, for example, rarely is that an issue, but what my staff knows to ask the question, do you have a new headache associated with this droopy eyelid, for example? Do you have new double vision associated with this? And then that's a person that they would get in much quicker than the average person who just has senile ptosis.
The other question is, sometimes I'll get texted by a reliable referring physician who will describe a case to me. I'll respond to them. They may just take care of the patient themselves, or they might refer to me later. Is there reliability in that?
It depends. So that's one, you can protect yourself a little bit by offering to see the patient, but asking them to confirm whether or not they want you to. So if you say, I'd be happy to see this person. If you want me to, can you please let me know? If they say, no, I think I got it, then they're not referring that patient to you. And so you're not. So then you're being asked a general question without regard to your own personal examination of that patient, which would be like if you were to ask me, how do you manage thyroid eye disease these days? Which would be different than saying, I want you to see this patient with thyroid eye disease that I think is losing eyesight. So getting sort of confirmation from that person that, no, they're going to manage it and they don't want you to do it, takes you off the hook.
Thank you.
Yeah.
We want to thank you so much.
Sorry. Thank you for the presentation. I went to one of these OMIC presentations in Maryland, where I'm based. I work for the federal government, and apparently I don't have OMIC, and I wanted to access the OMIC website for some of these educational materials, but there's a firewall now to prevent.
Yeah, I think there are some things where they put some things out and some things behind that firewall. I think probably to encourage you to consider OMIC which I'm not here to do, but to encourage you to consider them as your malpractice carrier. I can tell you if there's specific things that you would like to get to, I'm sure I can help you. I don't know exactly what the policy will be moving forward on that.
I think the speaker was saying that they were worried about AI scraping the information.
That's another problem. I think so. That's actually a better explanation that they want your business. But one of the things that we try to be careful about, I can tell you, one of my other roles is I was president of ASOPers, the Plastic Surgery Society, for a while. And we developed a knowledge base that we expect all of our fellows to study that's got a lot of really great information in it. And we put that behind a firewall primarily to prevent plaintiff attorneys from looking in there and saying, well, you say on your like definitive website that this is the way to take care of this, and this doctor didn't do it. So it's similar to that, maybe, that AI is part of it. Part of it also is plaintiff attorneys looking at these things and using it against us. But that said, I'm sure we can help you if you have a specific thing.
We want to thank you for your talks today. Great.
Well,
Really
thank you
great.
so much for inviting me. I'm very excited about the cookies.